Thank you so much, Dr. Antonio Giannakis and Brolakis, for inviting me to share something I'm very passionate about. Can we pause that or go back? I was just going to explain where we landed on this technique. This is where I am right now. I didn't start here. We tried a lot of permutations and iterations. In the States, there's a lot more pushback about using Transosseus and the benefits of Transosseus. So I was looking for ways to synergize with anchors and use hybrid techniques as a way to demonstrate utility and perhaps bring surgeons from the thought paradigm, just as we went from open to mini-open to arthroscopic, and there was a bit of a step into arthroscopic. So too, I was trying to have this synergistic approach. So this is called a true Transosseus hybrid technique, and we'll do the biceps as well. Okay, let's go ahead. So this is a right shoulder. This is true Transosseus instead of Transosseus equivalent, and it's a hybrid because it uses an anchor. This is a right shoulder from the posterior viewpoint. We're looking at the tear. Here we put an all-in just adjacent to the cable, and I actually tunnel a lot now from the inside because I don't have to see the lateral portal of the device. So I go ahead and plan the footprint at the same time for efficiency, and we use the awl, which has a smaller diameter on the tip, to microfracture the footprint as well simultaneously, and that's really the only thing that's been shown to increase healing rates. So we're making a lot of bone marrow vents here at the same time. We're planning our footprint in terms of the geometry and in relationship to the cable and the superior capsule. Then we bring the tunneler in with the scope on the inside, and we want to see precisely where we're putting the tip. And so this can be helpful. Sometimes that's a little bit more difficult from the subacromial space, or you may have to go to a posterior lateral portal. So here it's intraosseous passive capture, so we retrieve it very efficiently, and then we're going to manage this loop from the superior medial portal. In this case, we're going to pull a triplet of tapes in, and tapes will decrease the plastic deformation of bone. So we call this a triplet. That's the functional moiety of transosseous repair, in my opinion. Now we're showing here that we just tunneled right through the bursa. We didn't have to see it, and here you can put the limbs on tension and just shave around them. So you don't really have to worry about that. I worried about that in the beginning, but I don't worry about it at all anymore. Here we've put another triplet in, so we've got 2 triplet stacks. Now we're going to start passing the suture, and this is according to the surgeon preference. We're doing antegrade passage here, and we want to use a ripstop configuration. You can do loops, you can do Mason Allen equivalents. This is a MAC type situation that we're doing with an X-box. So we're doing a mattress stitch, linking the tunnels, and then we're putting the simples behind the mattress stitch for a ripstop effect. So now we've put these matching limbs together purposefully. That's going to be the mattress suture. We're going to bring these extracorporeally and join them with a knot, and then retrieve them back into the joint space here. Now, and then we'll clear the lines here. You can actually pull on the inferior limbs and position that knot wherever you wish. So it's just another thing of transosseous that you can't do with anchors, that you start to learn this Pandora's box of techniques. Now we've selected the blacks for simple sutures. I prefer an SMC knot. These are the vertical limbs of the box. So the blacks are going to be the simple sutures. We're tie the knots low and lateral with the post lateral. And here we're going to show the compression, the excellent double row compression of the tendon. We back that up with a couple of half hitches. And now we're going to tie the inferior limbs of the mattress suture to get them out of the way. And we're selecting to put the knot anteriorly here. So we pull on the anterior post, and I'm going to clear that knot anteriorly. So I'm planning the compression to try to maximize surface area compression from the X-box configuration. So you can see pulling on the anterior limb, and this is a very strong bone bridge. This is orthogonal to the grain of the bone, so the anisotropic properties of bone mitigate towards much less plastic deformation or cut through here. So we're tying that with the post anteriorly, so now that's cleared. And then the most complicated stitch for most people is the X stitch. Here I want the knot to land posteriorly, so we're going to select the posterior superior limb as the where the knot stack's going to land, and we're going to connect that with the anterior inferior limb. So this is the crossing limb. We bring these outside the cannula, and we're going to join them with a simple stitch, and we'll show you that outside in the next talk. We're going to clear these limbs from the superior medial portal and then go ahead and just join them back up. And then that'll be a completely independent, fully transosseous, what Krishnan called the X box. So you could stop there, but what we're going to do is leave these limbs long. And I've gone away from any hardware at the healing zone because they cause type 2 failures when you put anchors medially and they increase pain. So I used to do that with hybrid, but I've gone away from it. So now we're done, except in this case, there was a little bit of a dog ear. I didn't like it. So with unlimited fixation points and with so much suture, we never accept dog ears anymore. We're going to go ahead and put inverted mattress sutures in because we know we're going to come with an anchor later. So we're going to go ahead and tack this down. So again, the paradigm here is multi-fixation points. So we're going to increase our fixation point density dramatically on the tendon. So I'm going to go ahead and put 2 inverted mattresses in here. And this is using the tails of the sutures that I've already cut. So, no extra cost, just more efficiency. So now we're going to go ahead and bring those down and capture those into this lateral anchor, which we're going to put inferior to the horizontal limb of the mattress. So this creates an independent fixation point, increases your efficiency. So it's 1 anchor, but 5 fixation points. And it's a triple row construct. If you care about that, I think that's becoming an outdated concept relative to Transosseus. But here we are, so we're done. So that's 5 fixation points with tapes and true Transosseus hybrid. Here it is from lateral. So very robust fixation, very confident in that. This is the cartoon. This is in arthroscopy techniques. So now we're going to go to the biceps. So we release the biceps. This is a mid-lateral viewing portal. We're using the exact same portal that we placed the tunneler through, the Transos through before. This is called the Tokus technique. This is in press, arthroscopy techniques. So we're going to use the tip here, a trick here is to use the labral scorpion. It has a small hook on the bottom, which allows you to get into the groove, and it's much easier and faster. So we're going to pass these antegrade and whip stitch like an ACL. Multiple cerclage here will transform the longitudinal cut-through force into a circumferential compression force. The number of cerclages times the working length and the number of passes is going to be proportional to your pull-through strength. So we're going to add, once again, multiple suture passes, and this is, again, an advantage of Transosseus techniques. Here's another trick. We're going to go up into the interval, and we're going to have a secondary backup fixation through the interval through a soft tissue technique. So we're passing 2 stitches through the interval as well. So we're going to have 2 Transosseus tunnels, and here's a backup for a third fixation point, soft tissue fixation point into the rotator interval. Now we've owned the tendon. Now we're going to come in just above the circumflex. If you hit the circumflex, obviously there'll be bleeding, so we stay just above that. We stay slightly lateral in the groove. And we're going to go ahead and plan our footprint at the same time for efficiency, keep the all in, and then we're going to come up high in the groove and place our tunnel here. Bone's very hard here, as you know, and we have good exposure to bone marrow healing elements, as you can see them coming out there. So now we forward flex the arm. Tip here is to internally rotate slightly, and that allows the tip of the tunneler to go in. There we go. So we've internally rotated. Bam, the tunneler's in. This is the exact same portal. So here we go in real time. So generally takes about 15 seconds to make a tunnel, 15 to 20 seconds. And we're going to pass our transosseous tunnel here, and then we're going to utilize this as a passing suture. And we make an intra-articular pass, and we pull one limb of the tape back through the tunnel. And so we're done there. Now this is a little bit more advanced or complicated. I'll show a technique here that or an advantage. You see there's the anchor, and my tunneling point for my lateral entry point is going to be right in my anchor, so obviously we don't want to hit that. But what we'll do is just rotate the arm back a little bit, and we're able to visualize, and because we don't drill and we don't remove any bone, we compact the bone to increase the strength of the tunnel, actually. But we have a very small 1.9 millimeter poke hole here. So I'm just going to see where that's going, and we only need a millimeter or two of clearance, so we're going to scythe past that anchor. And sometimes I'll interlock these. We'll rotate superiorly, and we'll interlock the tunnels with the other tunnels. So you can make a web, or you can weave a sort of a cargo net there. Going in perpendicular directions. So here's this passing stitch. We're going to place the control suture where we want it, and then we just pull that back through. And so now we've got two Transosseus fixation points with multiple cerclages on this biceps. This avoids a wound infection or a draining wound in the axilla, and it avoids having to worry about the length-tension relationship because the length tension is perfect because we're leaving it attached. So there it is with multiple cerclage, Tokus technique. Those are 3 independent fixation points right there, and then we're gonna have a 4th backup fixation point. So there's 4 mechanisms in series to prevent the biceps from pulling through. And that's 9 fixation points. So it'd be hard to get 9 anchors, in a proximal humerus. So here it is from the inside. There's the cuff fixed down very nicely. And then we're going to release the biceps close to the labrum to increase the size of the biceps there. If it's hourglass, even better. And then we just leave that as a 4th prevention of pull through. And what I've found is when you take the biceps out of the pulley, it increases the failure rate regardless of fixation techniques. So I leave the biceps in the pulley, and if it scars in there in about 2 or 3 weeks, you've got a very low, extremely low failure rate, anecdotally, from what I've seen. Thank you.